All right, welcome everybody. I just want to do just a quick sound check. We unmuted ourselves. Let us know that you can hear us still.
Yeah, nice and clear.
Thank you so much. We've had some issues with sound in the past, just for various reasons. So if by any chance you aren't hearing anybody in the room, let us know, and we can always repeat the questions if we have questions in the room. But otherwise, we will get started. Hand it over to you.
All right. Okay. Hi, everybody. My name is Jen Peterson. I am currently a CRC in the Pediatric Hematology and Oncology Clinical Trials Office. Previous to that, I spent a couple years in pulmonary and critical care as a critical care CRC. So what I'm talking about today is inpatient enrollment, and I'm doing that from my experience in pulmonary and critical care. And hopefully we'll have some time and make this interactive with everybody in the room and online. Because I think in consenting, everybody has slightly different processes, slightly different habits and ways of doing things. So I'm going to talk through what my process looked like and some tips from my experience. And then hopefully we'll have some time to share your methods at the end or talk through any questions you might have. So to start with, finding your patients, and again, this is where things will differ. We use a lot of Epic tools, in particular reporting workbenches. You can also set up patient alerts, but for those of you who aren't familiar, in Epic, you can set up search functions that you can run a search for patients in a particular unit, or on a particular medication or with a particular diagnosis or a combination thereof, that would give you potential patients that would be available for your studies. Epic patient lists for unit also come in handy. I worked in critical care, so I had a patient list, so I could look at any given moment as to who was on in the ICU under the medical ICU service. So that I could glance through and see if there's somebody I had missed or somebody new that I hadn't seen. I tended to make sure eligibility criteria was present in workspaces. And so not only my workspace, but if there is a workspace for the fellows or for the attendings in the unit that you work in where you can post something, we would have eligibility criteria for the studies we were really focusing on in those workspaces so people could see them. In the MICU, we were fortunate that one of the practices they had was the nurses actually had a binder in their break room that was all of the research studies. So we made sure to keep the eligibility criteria up to date in those binders. So if the nurses were wanting to look for something, that was available to them too. We made small cards, so almost like a 4x6 card with eligibility cards that we typically laminated and gave to the treatment teams. So the attendings could keep them in their pockets, or the fellows or the APPs could keep them around in an easy way. So providing that eligibility criteria in that way. And just talking. So sometimes word of mouth are some of the best ways to find patients if all of the other things fail. So making sure the fellows know, particularly because even though we are only here during the day, the fellows are here generally around the clock. So sometimes the fellows would tell me in the morning before I even opened my computer that there was a patient I needed to look at. Our APPs are great sources of information. If you have APPs interested in research, make really good friends with them. They are excellent resources and helpful, and can also help you with patients. Residents, nurses on the unit, the more people who get to know you and why you might be wandering around their unit, generally, the more you're going to have people contact you and say, hey, I think this patient might be somebody to look at. And so all of those are great ways to find patients. short technical difficulty. There we go. Preparing to approach your patients. So once you find those patients, confirm eligibility and plans to approach the patient with the attending. I know a lot of times we do, right? Most of that work as coordinators, but I always made sure to touch base with the attending before I approached a patient, even if they had said yes earlier in the day. If I wasn't going to see that patient until later, if I could, I checked in with them, because you never know what their plans are for a patient. And some of their plans might then conflict with whatever research study that you plan to approach. So making sure that you confirm that eligibility and talk with the attending is always a good idea. Use names, right? Learn names from the notes about who's sitting at bedside, who's been with the patient. If there's a name the patient prefers to be called, we do have the preferred name, right, showing in the chart, but sometimes you'll find other information in the H&P notes. So read a few notes before you go see that patient. It always helps when you walk in the door to know who might be there. Also, how many might be there. So I say that because quite often, yes, you might only have 1 or 2 people in that room, but I once had a patient who had 12 adult children, many of whom were in the room. The others were sitting down the hall, right in the family center. So even knowing how many people you might encounter is always good to know before you walk over. Make sure you have multiple copies of the consent. There again, if you know that there's been, right, a child and a spouse sitting in the room with the patient, I always made sure to have copies for both of them so that they weren't trying to share a copy of the consent. So if you take multiple copies of the consent with you, hopefully you won't run into problems where everybody's got to share one. And talk to the nurse, which is going to be an ongoing theme here. Talk to the nurse. They often can provide information that might help you with timing in terms of when it might be best to approach the family, when it might be best to talk with them. If there's, for example, a younger child present, they might be able to tell you, well, they're getting picked up at this time. And so maybe wait until the child has been picked up. So talking to that nurse so that you can optimize that timing. The nurse can also tell you things about the patient and their family that can be helpful before you walk in the door. And so make friends with as many nurses on the units that you work on as possible. We love our nurses. So adjust that timing accordingly. So if they're going to be taken down for a procedure in 15 minutes, that's probably not a good time to, go in their room and try to consent. So make sure that there's enough time to talk to the patient. So are they going somewhere for a procedure? Is somebody coming to take an x-ray? Those kinds of things, so that you can adjust that timing accordingly. Make sure you introduce yourself to everyone in the room. I know the focus tends to be the one that you need consent from, right? Whether that be the patient or the person sitting next to the patient. But it may seem very simple, but sometimes I think we're so focused on what we want to do that we forget those kinds of things. Explain why you're there. Make it clear, right, that you're a member of the research staff and you're there to talk about research. Provide a very short description of the study. So I always recommend people should have a 30-second blurb about the study. So if somebody said, what study are you recruiting for? You could give them the 30-second blurb and they'd have a pretty good idea. So I would typically tell them, right, your loved one, because quite often I was consenting, not the patient, but the people with the patient, and talking to them about why their loved one qualified for this study. This is what the study is about. Do you want to hear more? If they want to hear more, that's when I actually give the consent form to people, just because sometimes handing somebody a consent form means they start reading the consent form and stop maybe listening. And to some people, the consent form can be really intimidating. So I kind of ease them into it by talking a little bit about the study and then saying, okay, if you're interested, then let's talk about consent. So, and this is where everyone has their own preferences. So find a system that works for you. And some of that is going to vary depending on the situations that you're in. I found in critical care in particular, because those situations tended to be a little bit more intense and emotional, that I would actually use that short version that's in the first couple pages with the boxes to give them a more detailed overview of the study. And then I would stop again and say, can I ask, right, you can ask me any questions right now, and do you want to hear more? That's the short version. Now we can go into greater detail. I know I had colleagues, right, in the same department who never used the first 2 pages of the consent. They started right in with the meatier parts. But I found in the ICU, it gave people a chance to kind of start to focus on what it was I was talking about and what was in the consent form. So it's just a nice way to build in another moment for them to say, yes, I want to talk about this. No, I don't want to talk about this. Or I want to talk about this, but I don't think I have the capacity to do it right now. So if you continue with that more detailed consent. I think everybody then in that detailed consent process has different things they tend to highlight. I think it's really important. A lot of families have concerns about privacy and their information. So one of the things I always tried to emphasize and explain to them in a little more detail than was on the paper was that members of the research team are covered by the same rules and regulations about health information that the medical providers were. And we all have to go through special training, right? And we're covered by these things. And so sharing information with us is like sharing information with your medical providers. That typically was a concern people had. I made sure, in part because of that concern, that contact information for the IRB, for the research advocates, was plainly obvious to them. I think it's in 3 different places in our consent forms. So I typically highlighted those things as well to make sure they understood there were resources for them beyond just the person standing in front of them. Because I think that's comforting to people that there are entities overseeing what we're doing. Questions. You are always going to have questions from the patients, from their families, from whoever else might be in the room while you're consenting. So if you can prepare for questions ahead of time, that's great. So think about, what would I ask if I was being asked to participate in the study? Or presumably if you've talked to the fellows and the APPs and the nurses about this study, what kinds of questions did they ask? Right? You haven't put them through a full consent process, but I'm guessing some of the questions they would automatically have about this study are questions that a patient might have about that study. So think of some of the questions that you might anticipate, because then you have the answers. If there's something you have to look up ahead of time, you can. I always make sure I pause throughout the process to ask for questions. Sometimes you will get random questions in different places, and that's because people are processing maybe at a different speed than the consent form. So making sure there are moments where people can stop and ask questions. If there's a really important part of the consent or really important part of the process that tends to be confusing, make sure you stop right around that space and make sure people understand before moving on with the other pieces of the consent. And if you don't know the answer, that's fine. Tell them you'll get an answer and get back to them right away. It happens, right, for everybody, that somebody is going to come up with a question you have never heard, and you're going to have to get back to them with that answer. And as long as you get back to them, right, that's not a problem. So after going through that whole consent form and answering all the questions that you can, and or addressing any concerns people have, I always offered people time to think or talk about it without me in the room, right? So I got to the end of the consent process, made sure they understood. And some people will tell you right away, okay, let's do it. And that's great. But oftentimes people will want to process, people will want to read that consent form through on their own. So making sure that they have time to think about it, talk to each other, right? The people who are in the room, that's important. So a couple things you want to make sure if you're doing that, make sure that they are aware if there's time constraints, right? Sometimes studies have to be started within a certain period of time of you know, when they were admitted to the unit, of when they had a surgical procedure, of when they started a medication, or they have to be on a certain level of medication, right, to qualify for a study. So if there are time constraints, make sure that they're aware that, right, these are the time constraints. So we have to, right, try to make a decision within that time. And then set up a time to return. So ask them, you know, how long would you like me to wait before I come back to check in with you? Sometimes they'll say, just give us 10 minutes and I'll go wait at the end of the hallway. And sometimes they'll want a little more time. So ask them when they would like you to return. Make sure they have a way to get a hold of you. So business cards, phone numbers, pagers, however you're usually communicating, make sure they have that number. I also then make sure their nurse has that number, because if for some reason the card walks out the door with one person, right, and the other person is left there, they can always call the nurse and say, can you get that research coordinator back for me? I also made sure the HUC nurses also knew how to get a hold of me. If for some reason the nurse wasn't there, people will end up, right, at the HUC asking for, right, I need to find my nurse because I need to find the research coordinator. So if you're leaving them to think about it, to talk about it, just make sure you've set up a system for letting them get a hold of you and coming back to finish the process, hopefully. So once they sign that consent, right, hooray, right? If a patient and family chooses to consent, make sure they've signed a clean copy of the consent form, which you all know, right? This is IRB stuff. So if they've scribbled on one, I typically had a clean copy. If they were going to sign, I had them sign the copy that was in my hand because I didn't always keep track of what they may or may not have written on the form as we were talking or after I left the room. You get the patient labels on each page for MedRec purposes. You make the copy for both the chart and for the patient. This is an important one. If family is signing consent, which again, often happened to me in the ICU, and the patient is not aware that the family is signing consent, make sure that the family actually receives the consent. So I was taught and made sure I never left a signed consent just in the room, because if that patient wakes up, right, they're not aware their family has consented to a research study, and then it's sitting right there on their table to read. So we tended not to want patients to find out their family had signed them up for a research study that way. So we tended to make sure that, right, whoever is signing that consent gets the copy of the signed consent. So they have it, and then the discussions can happen later when the patient is more involved. So making sure it gets to where it needs to go is important. We did do some remote consenting in the ICU, so I'll talk about what this process looked like. Again, for any of these processes, consult the IRB, make sure you're covered for everything in your studies. Remote consenting, we included in our IRB submissions, complete with a phone script. So I had a phone script if I was calling a family member about a study that I would follow, which essentially was my 30-minute speech about the study, right? And would you want to hear about this for your loved one? So on that very first call, I would introduce myself and use the script. If I was doing a remote consent, I also made it very clear with the treatment team, or had a very clear conversation with the treatment team to know what that loved one had been told. It's easier when they're on site and you can talk to the nurse in the hallway and say, what do they know? What have they not talked about with the doctor yet? If I was doing remote consenting, I made sure to consult the attending to find out what had been said to the family member, so you know what you're walking into. So I would introduce myself. I would use that phone script, which provides, right, an explanation for why I'm calling, the basic description of that study, and then setting up a time to call back, because what has to happen is that you have to get them the consent form. So you have to email them or fax the complete consent form to them. However, that might work depending on where they are and what they have access to. So then you would set up a time to call back after they had had time to look at that consent form. And on that second call, you essentially would go through the consent process just as you would if they were right in front of you. So go through the consent form, ask about questions. Page numbers help. So particularly on the phone, I would say, right, I'm on page 4, and I'm looking at this section of the consent form, so that they for sure were looking at what I was talking about, just to make sure they're kind of keeping up without the visual cues. You don't know whether they're with you or not. If they choose to sign that consent form and consent, they have to then scan or photograph every single page of the consent form. So not just the signature page, it has to be every page of the consent form to send back to you. And I would provide directions for sending it back to me. Generally, it came through email. And I would say, could you please include in your email, right, we spoke on the phone about this study, and I am attaching a signed consent, right, for my loved one, just to provide a little extra documentation that would go along with that consent form. Remote consenting is possible, but really important to make sure it's included in your IRB, and that you're following all of those rules. And some general tips, just things to think about. Again, I think timing is really important. So working with the nurses to know what you're walking into, whether a different time might work better, if that's possible, right? Sometimes timing doesn't allow us to choose. But if, right, you can choose when to go see a patient, the nurses are gonna know, right, when they've had a procedure, when they might be groggy for the procedure. If they've been an inpatient for more than a day, the nurses will probably also tell you they're a morning person. They're not a morning person. Come in the afternoon. They provide a lot of great information that provides, right, the greatest opportunity for a discussion with the patient and their families. So timing is important, and the nurses are really one of the best sources to figure that out. The other thing is, if you're working on a floor that maybe you aren't as familiar with, knowing when rounds happen, knowing when the team is coming in and out, knowing when labs are being drawn, some of those things might also factor into that timing. Spend some time talking with the family. Listen to them talk with each other. Some of their concerns or their questions, some of them might not want to ask you, but they're asking each other. And if you're in the room, right, being able to maybe pick up some of that information and offer some additional information to them is helpful. It can make it a lot easier for them to ask you questions. It might provide insight into their concerns and where their concern is coming from. Sometimes, right, they will ask questions that go around in a circle, but you figure out that their real concern is, right, not anywhere in the questions they've asked you, but is in the center of that circle. So the more that you can learn about the patient and their family and how they're talking to each other, sometimes that can make it easier for you to have those conversations and address concerns that they have. Give them as much time as possible to think and process. I think sometimes we're very eager to get that enrollment and get things going, right? We walk in there going, okay, if they consent by this time, then we can have labs ordered by this time, and we can have, you know, their scans done at this time, and then I have to call this, right, PI to do a physical. We're thinking about all those logistics. That patient and family are not. They're just simply thinking about, do I want to do this, and what might this mean for whatever I'm facing? And so if you can give them time to think and process, I think it tends to be very helpful. I think they also then tend to be more confident in the procedure going forward if they do consent, because they really have thought it out and are comfortable with it. So be accessible to answer questions during that time. Again, making sure they know how to contact you, stopping by. I would stop by periodically if it was a family who was just not quite sure. If I was on the floor, I'd stop by and say, hi, how are you doing today? You know, have you thought about this, or do you have any additional questions? It never hurts, right, to stop and check in a patient's room. I will also say, right, the next one, if they do consent, check in with them later, like even if you don't have to. I think that does a lot for our patients in terms of the confidence they have in research staff, and feeling like, right, they didn't just come in here to get my consent. They actually care about what's happening to me and what's happening, because, you know, many patients come back and forth and can be a part of multiple research. So I always thought these are also potential research subjects for somebody else down the road. So if I can leave a good impression of research, I would stop by their rooms just to say hi and see how they were doing, make sure everything was going okay, and that they didn't end up with questions afterwards. I think it's just, right, an extra thing to do if you're walking by on the floor, to just stick your head in and say hello. That's helpful even after, right, consent has been had and you've started the process. So that's kind of where my experience comes from, and things that I learned going through the consenting process and working with inpatients. So I kind of wanted to make this very interactive, because it is such a process that you develop your own way of doing things, that maybe there are questions we're happy to talk about, but also if there are other coordinators who want to share their tips and thoughts about how to do things. All of us have good stuff to share. So
yeah, this is Mary. I work in transplant. I've got a tidbit of information. I was audited back in Texas, where we came from, and one of the main things that we were audited on were consent forms for, and they were minor studies, but moral of the story is, if you have a Spanish speaker or any language aside from English, the coordinator signs English, the participant signs the consent in the language they understand, the witness signs both.
yes, that's
Most
a very
people,
good tip.
I don't think, realize that.
Yes, we didn't talk about foreign language consents, because that was yes, that there's so many issues with that, but yes, that's a very good tip. You should only sign a consent form that you understand, right? It's kind of the rule of thumb there. So,
and
yes.
then when it comes to children, assent is absolutely necessary. Them not acknowledging that they don't want to participate is not. And if you have a consent form, and I don't know what the age here is, back in Texas, it was 10. But if they do not actually acknowledge and sign their name or make a mark, it's not even a protocol deviation, it's violation, which is worse.
Yeah, here, so I work in pediatrics, so this one I know. Here, it depends on the study. So each study kind of has different age ranges depending on the study and how complicated it is. And some studies actually have a separate form for certain ages. So like, for example, I'm thinking one of our studies, we have a form for children aged 7 to 13 that's simplified. So they would actually sign their assent on that form. And then if they were, right, 14 or above, they actually sign on the regular consent form. So it varies here by study. And the IRB, right, affirms that determination. So sometimes there are also separate assent forms versus documenting assent on the consent form. So it varies.
Gotcha.
Mm-hmm.
Good to know.
Yeah. Other questions or tips, things people can share?
I have some tips.
Oh, Char has tips.
Yes. One thing to remember is that when you talk to the nurse on the floor, that information might not get transferred to another nurse. So you do want to make sure that you're popping up there quite often to talk to the nurses. Also make sure the attending is aware that this patient is in a study. Sometimes they will actually let you put a sign someplace either in the room or right outside the room saying that this patient is in this study. So definitely see if you can do that. Don't rely on the RNs to do your study procedures. They will do their best. They are very interested in research. However, the patient is their first and foremost concern and focus. So if you need blood pressure taken at a certain time or urine measured or whatever, don't rely on them to do your study procedures. Certainly they will help if they can. Also, if your patient gets moved, make sure the study and the orders go with the patient. I've had that happen where a study was moved, our patient was moved from ICU to the floor, and the patient didn't get drugged for 3 days because the order didn't go with the patient and the meds didn't go with the patient. So make sure that you know where your patients are and that orders are moved along with them.
That's a big one.
Yeah.
That's a big one.
I do have a share in the chat as well.
Sure.
From Bridget. Bridget said, my study had success remote consenting with 253 participants in REDCap using tablets. Once COVID happened and after COVID, we used WebEx to remote consent in real time. It was much easier than having the participants scan or email their forms in.
Yes, the problem is for many studies, which most of the studies I was consenting for, REDCap is not FDA compliant. We do not have that module here at MCW. So for studies that don't include INDs, that works, but it's not compliant for studies governed by the FDA. So for some studies that works in the REDCap and other studies, it does not. But it's nice when you can do it. Hopefully, I think they've been working on that. Maybe it's coming soon.
So Jennifer, hi. This is Amit. Yeah, as an institution, we don't have a Part 11 compliant system. What do we do in that situation though? If we can't reuse REDCap, what else can we use? Because I don't think we have any system.
No, I don't think they keep telling me that there's a module that is FDA compliant in, I think, Florence, actually. There's a consenting module for Florence that they've considered. But as far as I know, and our Adobe is also, we don't have an Adobe FDA compliant secure signature system either. So if it is one of those FDA studies, then you can use the remote process I talked about. And I think that that's pretty much our limit. But I'm not sure on that. The person I always go to, the consent guru, at least, was Sarah Griffin for a long time. I know they've changed some positions over there, but yeah, as far as I know, there's not an easy remote consent that's FDA compliant. Unless,
okay, thank you.
Do you know of any? No. Okay, we haven't.
I do also have a question in the chat.
Sure.
So the question is, what is your guidance on consent assents forms for patients who are English speaking, but their parent is non-English speaking, with the same concept of signing only a form in the language you understand applied?
Yes. So in that situation, if there was a separate assent form the patient had to sign, we would most likely have them sign the English consent, but then the parents would need to sign in whatever language, right, they are comfortable with. So most of our consents are translated to Spanish as well. We do have a few other languages accessible to us, but yes, we would still then have, if the child was more comfortable with English, we would have them sign their assent form in English, and then the parents would sign a consent form in the language they're comfortable with.
So I can add to that. Again, going back to the audit, it matters what is listed in EPIC as the preferred language. So typically, whatever their preferred language in EPIC is, that's the one they need to sign, or it needs to be changed. I don't know if that's the same here, but it was a big deal in Texas.
Okay.
Because if they sign the English consent form, but EPIC says that their preferred language is Spanish, you could see the confusion.
Yep. Mm-hmm.
But we don't have any other questions in the chat right now.
Another tip I would offer is to make sure that investigational pharmacy is looped in with your patient. A lot of times the patient has to receive drug by a certain time or within a certain time frame. So you want to make sure that you have them on board so that you can get your drug up there to be administered in the correct time.
Yeah. And timing is really important on that too, because if you're getting towards late in the day, I know one of our studies, if we were consenting later in the day, like when it got past like 3:30 towards 4 o'clock, they would often then say, okay, go to central pharmacy, right? For some studies, if your study is cleared in central pharmacy. And so we would end up, right, because we were picking up drug past 4:30 mark, right? So that's where timing becomes important as well with IDS and maybe going to central, right? If it was going to be close, we would have central on call and ready to go.
At 3 o'clock in the morning, investigational pharmacy is not open.
They are not open at 3 o'clock.
Not at 3 in the morning.
I'm also not working.
There have been times that I was.
Oh, all of that difficulty. And then we can also say, you know, Shar and I worked on some COVID studies, but it would apply to, I think, a few different infectious disease situations. If paper can't leave the room, you would sort of follow, you would obviously be doing a face-to-face consent and the person would be signing the consent, but then we had them photographing, right, the consent forms and using a similar process to remote consent to document it. Because that became an issue with COVID and not allowing paper to leave that room. So other fun things. I think be prepared for anything. I have, right, obviously consented one person, but like I said, I went in the family room and consented the 12 adult children, right? So I had 12 copies of that consent form and 12 people asking me questions. You sometimes just have to go with the flow and do what's needed.
Have you had an experience with recruiting from the ICU? Any of the ICUs or adult or peds, and what extra challenges does that pose?
My experience recruiting is on the adult side, in the ICU. And so, I mean, I think part of the challenge is, right, it's timing. For some studies, right, you have to get them within a certain number of hours of them being admitted to the ICU. And that typically is a traumatic experience for the people that you're working with, because their loved one is generally, there have been maybe, I can think of maybe 2 where I actually consented a patient because the patient was conscious and not intubated and, right, able to provide consent for themselves. Otherwise, I was always working with LARs. And they're often adjusting to the trauma of seeing their loved one in that position, generally attached to a lot of tubes and cords and things, and getting information from the medical team. And now I'm in there asking them, right, about research. And so sometimes that was really challenging, depending on the case, right, and the timing. And I think that's one of the challenges, is that I didn't always get to pick my time. Sometimes I had to go in there knowing what the time limits were. So I just, tried to be as sensitive as possible and listen to them as much as possible, because those were often the cases where they talked a lot about a lot of things in and around the research process that were happening in the room. So, and not answer questions that I didn't know the answer to was also really important in that situation, because it is so intense. And again, in the MICU, I will say, I also had incredible cooperation with my APPs and with the nursing staff who, and nursing administration, who was very involved in the research process and approving the studies that were allowed to recruit in the ICU. And keeping them up to date, again, even just regular communication with them about where the studies were that were recruiting in the ICU. I sent a monthly report to nursing administration in the ICU. And so I think really working with that team was helpful, because I never had to ask a nurse to do a research procedure, but the APPs would jump in and do things for me, because they were a little bit more free sometimes to do things in the timing of things. So I really benefited a great deal from having a great team to work with.
And I've also had to consent family members for patients that were in the trauma rooms. Yeah. And my biggest tip for that is to stay out of everyone's way, because they are, again, their focus is the patient. There are usually anywhere from 5 to 10 people working. You have to get your consent, but again, be respectful of their time and stay out of their way, because nothing will get you kicked out of the room faster than someone turning around and bumping into you.
Yeah.
So, I mean, for the ICUs, do they prefer e-consent or remote consent instead of in-person, just given that the seriousness of the patients and potential for cross-infections and so on and so forth?
No, the preference was face-to-face. If the family was there, we did everything we could. If we knew the family was there, I have spent several hours sitting at the little nurse's desk outside of their rooms waiting for family to come. And so we definitely preferred face-to-face consent. We did have access. There are family conference rooms near the ICU so that we could use. I did run a few consents in those spaces, but most of the time that was because the medical team was coming in to do something and we were mid-discussion, so we moved out of their way so they could treat the patient. But the preference was still face-to-face consenting.
Thank you.
I should say that's the other thing, I guess, though, on the infection question, you always pay attention to any signs on the door in the chart, but they also in the ICU typically put a droplet, precaution, so if you need a gown and glove and mask and everything else, depending on what's happening with that patient. So be aware of those signs in the chart and on the door. And the nurses are, helpful with that too, because they'll stop you going in the room if you don't have on what you're supposed to have on. So we did have patients that had restrictions that we would gown up to go in, to talk to them. So be aware of those signs on the door or the charts or clipboards hanging on the door sometimes.
We have a few minutes left. Even if someone doesn't have a question about enrolling inpatients or remote enrolling, if someone has a question about something else or looking for some information, please feel free to speak up too. One. Okay. Yes, we're done.
Fine. All right. Well, thank you, everybody.
Yes,
Thank you so much for a great session. All right. Everybody have a great day. Thanks for joining us on the line, and those who are in person as well. Thank you.
I do want to add, I like the tip that you left when you said to continue to check on the patient afterwards, that it gives a good impression of research.
I agree.
Yeah.
So,
It does.
yeah.
And I think, right, particularly, I thought about that a lot in the ICU. I mean, we had treatment and non-treatment kind of studies, and I thought, you know, I mean, you never know who and that patient may say no to me, but the next person, right, they may listen to in a different way if I'm nice to them, right, kind of thing. I think it makes a difference. I hope it makes.
I've had patients or family who don't remember the nurse's name or even the doctor's name. They remember my name.
Right.
Oh,
Yeah.
here's my study code.
It's good, right? That's what we want. Well, sort of, right? We want them to know their doctor's name. That probably is helpful.
Sometimes if they're in, you know, inpatient, they're seeing a lot of doctors.
Yeah, a lot of doctors.
And you're kind of that one face they see a lot.
Yeah.
Hopefully not a lot, but sometimes
Yeah.
it is a lot.
You're at least a face that's probably not gonna poke them or wake them up
Right.
at 4 a.m.
Exactly.
to take their blood pressure.
Right.
Those things. So
You also should have added not to make any medical recommendations or.
yes, no medical recommendations. Yes,
Right.
always defer to the treatment team.
Yep.